Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman, Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Hello.
Hello, Doctor.
Hello.
Good morning and welcome everyone to another edition of the Hindu's Wellness series of webinars. This edition of the webinar is presented with Naruvi Hospitals, and we are going to discuss an important topic today, which is epilepsy management. According to the World Health Organization, around 5 crore people across the world have epilepsy, of which nearly 80% are present in the low and middle income country like India. So although epilepsy is a chronic condition, WHO estimates that 70% of these people can lead a normal quality of life without seizures if they are diagnosed and treated properly. And that is going to be the key focus of our discussion today, how to manage epilepsy. And to throw light on that, we have 3 experienced doctors with us. Let me take the pleasure of introducing them to our viewers. First, we have Dr. S. Chitrambalam, who heads the neurology department at Naruvi Hospitals. He completed his MBBS from Stanley Medical College and went on to do his MD in Coimbatore Medical College and DM in Madras Medical College. He has an experience of more than 20 years. He has worked for many famous hospitals, including IRP Perundurai Medical College, Sri Ramachandra University, Narayana Hrudayalaya in Bangalore, Mayotte Hospital, and St. Isabel's before he moved to Naruvi Hospitals. He received Professor Muniratnam Endowment Gold Medal for securing highest mark during his MD program. He also stood first in Tamil Nadu in the entrance examination for DM Neurology program. Welcome to the discussion, Doctor. We also have Dr. S. Muthukani with us. Dr. Muthukani is the consultant neurologist and epileptologist at Apollo Hospitals in Madurai. He did his MBBS and MD from Madras Medical College and went on to complete his DM Neurology from All India Institute of Medical Sciences in Delhi. He also subsequently did a fellowship in Amrita Institute of Medical Sciences and a certification from Cleveland Clinic in Ohio, USA. He is credited with starting the epilepsy surgery program for the first time in South Tamil Nadu. He is also the winner of a special scholarship during his MBBS program from the Chief Minister of Tamil Nadu. Like Dr. Chitrambalam, he was also a state topper in the DM Neurology entrance examination. He has won a number of awards. He regularly stood first and won medals during his MBBS, MD, and DM programs. He was awarded the first prize by Association of Physicians of India, Tamil Nadu chapter, for clinical examination in internal medicine in 2014. Welcome to the discussion, Doctor.
Thank you, sir.
Last but not least, we also have Dr. Bhupesh Pugalendi with us. He is the consultant neurosurgeon at Naruvi Hospitals. He did his MBBS from Madras Medical College and DNB in neurosurgery from Apollo Specialty Hospitals in Chennai. He underwent subspecialty training in Sri Ramachandra University and Claudio Munari Center for Epilepsy and Parkinson's Surgery in Italy. Before coming to Naruvi Hospitals, he has served in Apollo Specialty Hospitals in Chennai and Mayotte Hospital in Chennai. His areas of interest include neuro-oncology, cervical disc replacement surgery, and epilepsy surgery. He has attended and presented papers in a number of conferences. He is a member of the Neurological Society of India. Welcome to the discussion, Doctor. I welcome all the viewers who are joining us this Sunday morning. So the pattern of this discussion is going to be presentations by 3 of the doctors, and that will be followed by a Q&A discussion. So I request all the viewers who are joining in to drop any questions if they have in the Q&A box of the webinar, and I will ask the doctors these questions on your behalf. So let me first take the pleasure of inviting Dr. Chitrambalam to give his presentation. Dr. Chitrambalam, over to you.
Yes, sir. Thank you, Mr. Panvasant. Good morning, viewers. Good morning, friends. First of all, I thank Naruvi Management and the Hindu magazine for giving us a wonderful opportunity to talk to the public, and so that they can be made to understand what is epilepsy and what basics a public has to know about epilepsy. Here, why this topic was selected again is epilepsy is such a common disorder that many people suffer from it. As a statistics was given by Panvasant, It's one of the very common neurological disorders that affects the public at large. So in one way, we realized that the knowledge of people about epilepsy has to be sufficient so that they seek a proper medical help at the proper time, so that not only they suffer, the family suffers. The great social responsibility of the Hindu magazine and our chairman, Mr. Sampath Viswanathan sir, that has resulted in this series of wellness series. And in neurology, we have opted for epilepsy because it is one common disease that the public should know well. Now, about a few years back, say 20, 30 years back, epilepsy management was simply patient recognizes that they have a jerky movements, they call it a convulsions, fits, then they go to a doctor, get some medicines, and if it is controlled, it is good. If it is not controlled, not only the patient, the whole family suffers. There are a lot of social implications of this uncontrolled epilepsy. But recent days, the diagnosis and management of epilepsy, like any other field of medicine, say the coronary care, say the cancer care, say any other disease care. So the epilepsy management has reached very big heights that the specific diagnosis of epilepsy is nowadays possible in specialized centers where the epilepsy units have been set up. And the basic idea of this epilepsy is we still come across patients coming with epilepsy. If you listen to the parents of the patients affected with epilepsy, or you listen to the husband or wife or the relative, brothers, sisters of these patients, it is very distressing to know that the whole family is disturbed. If you see a agonizing epileptic fit, a terrifying fit, if the patient has a jerky movement, he loses consciousness, he falls, injures himself, bleeds from the mouth. If one family member is seeing this, the only request that they make to the doctor is, doctor, you do something. We don't want to see it again. The pain can be only felt by the family members of people who have epilepsy. So that is the main reason why the Hindu magazine and the Naruvi Hospital management have asked us to just talk to people, talk to the public about epilepsy and what improvement has recently happened, so that with the available technology, we can bring in the high-end technological things to the diagnosis and management of epilepsy, so that the patients, as Panvasant said, about 30% of the people, 70% of the people, the management of epilepsy becomes a little simple, meaning that the epilepsy is controlled with drugs. The rest of the 30% of the patients, epilepsy is not well controlled. It is what is called a refractory epilepsy, about which Dr. Muthukani, who is an expert in epilepsy, will talk. And these cases, when you come across in refractory epilepsy, we find that drugs are no longer useful. It is the role of neurosurgeon. Dr. Bhupesh, who has undergone a training in Italy about epilepsy management, he will talk to you about what are the equipments that are available in recent years, recent months, to treat patients with epilepsy. The whole idea of this webinar, the whole idea of epilepsy care is we don't want not only the patient, the entire family to suffer the pain of witnessing an epileptic event. See, you see a patient throwing a fit. For example, in the so-called GTCS, GTCS is a common term used by doctors in patients with epilepsy. GTCS is generalized tonic-clonic seizures. In this, the patient first becomes unconscious, loses his posture, falls, injures himself. You see, we have seen many times patients who are waiting for a train in an electrical. We had patients in Chennai where patient waiting for an electric train throws a seizure, falls into the railway track, and the train run over his leg. The leg is amputated at the age of, say, less than 25, 30. So these are all dire consequences which you cannot imagine. So the impact of an uncontrolled epilepsy, not only on the patient's life, but on the entire family, is devastating. So that the Hindu and Naruvi are now interested to let people know that epilepsy is something more, something beyond what people think what it is. So epilepsy, people first should stop having the myths about epilepsy. People should not think that it is something that is created by some evil forces, and they go for all native sort of remedies and magic remedies. No, it is not so. Epilepsy is a disorder of the brain. First, you have to understand that every patient has a system called the central nervous system, which constitutes the brain and spinal cord. Epilepsy is a disorder which originates from the brain. So, what is this? What are these words that are used by people who are concerned in neurology? So, two commonly used words. One is a seizure, another one is epilepsy. What is the difference between a seizure and epilepsy? So, a seizure is nothing but the patient has the brain, one part of the brain, suddenly it becomes over firing. So, the excessive and abnormal firing, excessive and abnormal neuronal activity from some part of the brain is what is known as seizure. This will manifest with signs and symptoms. For example, if it starts in the motor area, patient will have a jerk. If it starts in the sensory area, patient will have a electric shock-like sensation, all these things. So, an abnormal, excessive electrical neural activity, electrical firing from the brain is called a seizure. And what is this epilepsy? Are all seizures epilepsy? No. If a patient has a tendency to throw seizure without any provocation, it is what is called enduring predisposition, meaning that, for example, if a patient is a normal person, the sodium is normally between 135 and 150. If it falls below 110, from 135, due to some reasons, if the sodium level falls below 110, the patient will throw a seizure. This is not an epilepsy. Once the sodium is corrected, it comes back normal. The patient never throws an epilepsy. For example, a patient who is an alcoholic, he has a bout, so the so-called rum fits. If he drinks excessively or he suddenly stops, he will throw a seizure. This is only a seizure, not that this patient will have an epilepsy. So what is epilepsy? What is seizure? Seizure can be due to many causes where there is a provocation. And epilepsy is something where the patient is having an enduring predisposition to develop seizures. Not only that, the epilepsy has a lot of cognitive, neurobiological, psychological, and social consequences. So epilepsy is a disorder, as seizure is a part of it. And in addition to that, it has a lot of consequences. The consequences are cognitive, psychological, social, and neurobiological. So, in addition to analyzing and treating seizures, it becomes a responsibility, it becomes a social responsibility of the medical fraternity to make people understand what is epilepsy so that they seek medical help, they seek appropriate medical help and take appropriate treatment so that the entire family comes out of agony. I tell you again and again, if people who do not know about epilepsy, if they have one family member with epilepsy and they see the patient suddenly falling and throwing a seizure, bleeding from the mouth, becoming unconscious, alarming, disastrous. So we don't want any family member to suffer. We want to give a quality of life to them. And again, there are a lot of myths. Epilepsy interfaces with social life. Epilepsy interfaces with, for example, people have to understand that epilepsy is not always equal to jerking. See, there are mainly two types of seizures. One is a focal, another one is a generalized. In focal and in generalized, broadly there are two classifications. One is a motor, another one is a non-motor. For example, if it is a generalized non-motor, it is an absence epilepsy, meaning the person will have even up to 10 to 50 times a day. Suddenly, for a few seconds, he will stop doing his work. Then he will resume the work. So he will not fall. No big automatisms most of the time happen. So this absence is a generalized motor, but the non-motor. In generalized motor epilepsy, what you see is patient has jerks. Now, this is what is known as generalized tonic-clonic seizures. What is this tonic? What is this clonic? Normally, when the tonic phase first starts, the patient will lose his consciousness and he will lose his posture. That's the most dangerous part of it. As I told you, he may fall into a well, he may fall into a fire, in a cooking, in a kitchen. If the seizure occurs, we have seen, like Dr. Muthukani will be showing the consequences of the burns. The whole hand is burned, the face is burned. So this is a losing. After that, the whole body goes into flexion, then sort of an extension, and this will last for a few seconds, less than 20-30 seconds. But after that, it will be followed by what is known as a clonic phase. In the tonic phase, sometimes we find that the respiratory muscles also become tonic. So they make a big noise, and this is what is known as epileptic cry. So many times we come across patients attend saying that suddenly we heard a loud noise. This boy was crying, shouting, so we went. So that is epileptic cry that calls for the tension and people come. After the epileptic cry, which occurs in the tonic phase, people go into the clonic phase. And once the clonic phase comes, there will be a jerky movement of the whole body. And this will be lasting about, say, about 1 to 2 minutes. And during this time, patients' muscles, all the muscles in the body suffer. So that in the post-ictal phase, patients have a headache, body pain, confusion. So these are all the classical features of a generalized tonic-clonic. People have to understand that we see many times patients are brought to the hospital with a generalized tonic-clonic. It is very rare to see people coming with a non-motor seizures and with the focal onset seizures. And when they come to the hospital with the GTCS and they say, this is the first ever time my son has had a seizure. But you really go into the history, a patient who has been brought with a generalized tonic-clonic seizure would have had many times focal seizures. What are these focal seizures? These focal seizures can be, it can be a motor or sensory. The motor focal seizures, motor or non-motor. The motor can be a clonic phase. It can be a clonic conversion of one limb or one part of the face like that. If you see the non-motor focal, you find that these patients can have autonomic features. It can be purely autonomic. They can have just tachycardia, palpitation. It can be a behavioral arrest, or it can be a cognitive one, or it can be a somatosensory, or it can be emotional. These are the things that are commonly missed. For example, many times I have seen patients are brought with one GTCS. When you take, they say it is the first ever time in life it has happened. But when you inquire, they say that the child has seen colored auras. Many times he has seen colored, and the child has been has had a blank spell, suddenly daydreaming. Teachers complain that the child is useless, daydreaming child. He is not listening. Actually, all these would have been a so-called focal onset seizures with a loss of awareness, or it can be an absence seizure. So there are a lot of patients where the epilepsy is missed, and these children are branded with some other diagnosis. So here in the, I think I have given a brief introduction of what is a seizure, what is an epilepsy, what are the basic concepts in this. And here I want again stress that here Dr. Muthukani and Dr. Bhupesh are going to talk about the refractory seizures. The most important thing is the refractory seizures, where the whole quality of life of the entire family is gone. So this is the area that the epileptologists and neurologists and the hospitals which have an epilepsy unit play a major role. So here the epilepsy has to be diagnosed precisely where from which part of the brain the epilepsy is originating. Who is the culprit? Where is he hiding? Find it out, knock it off. Then permanently there's a cure for epilepsy. And this can be sometimes done brilliantly with some drugs or other therapies like vagal nerve stimulation and so on. And sometimes it has to be done only with surgical exploration. And in surgical management of epilepsy, there has been a lot of advancement. So that recently even the robo has been used in surgical epilepsy of refractory epilepsy patients. So I thank you all for the opportunity, and I want people to understand about epilepsy. They can read about epilepsy, and if they have any doubtful clinical picture in the family, for example, a child is, the teacher says that your child is inattentive, your child is daydreaming, don't call it daydream. Bring the child to a pediatric epileptologist or an epileptologist or a neurologist and try to make the diagnosis clear. And if the patient really throws a seizure, don't neglect it and try to go to the doctor. It may be a simple treatable condition like a neurocystic psychosis. And again, I want to stress that nowadays we see more commonly a condition called autoimmune encephalitis. Autoimmune encephalitis is your own immune system attacks your brain, and the child or the adult comes with an epilepsy, and this is very eminently treatable with immunomodulator therapy. And autoimmune encephalitis is a very important condition which manifests with epilepsy, eminently treatable. Many times we see that a patient with autoimmune encephalitis was unrecognized for months together with established lesions, and sometimes it is very difficult to treat. At the stage only they land up in hospital. So any doubtful neurological disorder, if you feel that is not very significant, don't neglect it and try to consult a neurologist, try to consult the epilepsy center, where even a very, very treatable diagnosis like autoimmune encephalitis, neurocystic psychosis, tuberculoma of the brain, a small lesion like a cavernoma or a glioma has to be removed. And in addition, if it is truly drug resistant, these drug resistance cases are very well handled by surgical therapy. So I thank all of you for the patient listening. Thank you.
Thank you so much, Doctor. Thank you for really driving home the importance of getting the right diagnosis and treatment, and by highlighting the importance of that, because it is not only a physical condition, but it also affects a person psychologically and socially. We need to be aware of that, and because of that, it has to be diagnosed and treated at the right time. Thank you so much, doctor. Now, can I invite Dr. Muthukani to go ahead and make his presentation?
Sure, sir. I'll just share my screen. So at the outset, I'd like to thank Dr. Chitrambalam sir from Naruvi Hospitals and Hindu Magazine for giving me this wonderful opportunity. So after that excellent and emotional introduction about epilepsy and its management, for the next maybe around 15 minutes, I'll take you to what is a drug refractory epilepsy and how should we control drug refractory epilepsy. So I'll briefly introduce that drug refractory epilepsy, what is it, and how does it impact on the patient's quality of life, and what is the actual definition which is given for this drug refractory or drug resistant epilepsy. It is nothing but when a patient is not responding to the anti-epileptic medicines which are given to them, that is what called as drug refractory or drug resistant epilepsy. And what is the role of epilepsy surgery for those people, and finally some take-home messages for those people. So I'll start off with a case. So we had a 7-year-old boy. He was right-handed, born out of non-consanguineous marriage with a normal birth and development as other kids. He had an average scholastic performance with his seizures started from the age of 5 years. So with a duration of 2 years, he came to us. So his semiology means how does the seizure came? So it manifests. So it manifests like an asymmetric elevation of both upper limbs with uprolling of both eyes. So his seizures used to happen in clusters. Clusters means the seizures will happen together. So in an individual cluster, he would get something around 5 to 10 seizures per cluster with a very frequent clusters, daily clusters. Because of so many frequent seizures, he started having a cognitive regression. His IQ started falling, and he also had a repeated falls. Already he was on 7 anti-epileptic drugs because none of these medicines were really working for him. So with that condition, he came to us. So I'll at the last slide, I will tell him like what we did for that child. I'll go on to the talk proper. So we know that it's already discussed that epilepsy is a very common neurological problem. And India, like all these middle income and low income countries, are hugely suffering from epilepsy. It increases the risk of morbidity and mortality also. And as Dr. Chitrambalam sir said, 1/3 of people with epilepsy, they are actually resistant to the anti-epileptic medicines. So those people, what we can do. So for example, this patient, she was cooking at the time of seizure. So she put her hand into the stove. So that's how she developed a significant burns involving the left arm. So how does the seizures impact in epilepsy? So if you look at the study which came from Canada, people who are having repeated seizures that they called as active epilepsy, they have more number of people are suffering from mood disorder, especially depression. So they have major depression, and these people felt that they have a huge social stigma. They had significant limitations in their education. They needed assistance in their day-to-day life, and many of the people were prevented from driving because those are the laws in Canada. So even in developed countries, people with epilepsy are facing several social problems. So it's not only about seizures, it's a huge social stigma and subsequent problems in the day-to-day life. So that's why we need to control seizures completely. So it's not only morbidity, it's also a mortality. So if you look at the mortality risk, the risk of dying when the patient had epilepsy is significantly higher when compared to the normal population. It is almost 6 times higher than the normal population. But when the patient seizures are controlled with the medication, the chance of dying because of epilepsy, so we call that as SUDEP. SUDEP means sudden unexpected death in epilepsy patient. So that significantly comes down if the patient seizures are well controlled. So what is the definition of drug refractory epilepsy? So when the patient is not responding to 2 properly chosen medicines with adequate duration, adequate dose, we call that as drug refractory epilepsy. And how can we identify patients with the drug refractory epilepsy? So generally, if you start any patient with epilepsy, the first medicine will work in nearly 50% of people. And the remaining people, if you start the second medicine, maybe 10% may respond further. But once they fail first two anti-epileptic drugs, then the chance of responding to the further anti-epileptic drugs are very less. It's less than 5%. So that means whenever any patient with epilepsy, if they are not responding to the first two drugs, then they unlikely to respond to further trials of anti-epileptic drugs. So can we predict patients with drug-resistant epilepsy? This study came from All India Institutes where I was trained. So if you look at that, when the patient had abnormal MRI, or suppose if the seizure frequency is higher, or if they had a past history of fever-induced seizures, and when they did not respond to the first anti-epileptic drug, so these things could predict that the patient will have subsequent drug-resistant epilepsy. So suppose if you have a patient with a drug-resistant epilepsy, why should we consider epilepsy surgery? Why don't we wait? Because if the patient having continuous seizure, that will affect the brain functions. The epilepsy network will become more complex over the period of time. And with the longer epilepsy duration, even if you do surgery, the chance of seizure freedom will become less. So that's why we should act fast. So do we have any efficacy? Do we know that the epilepsy surgery work in drug-resistant epilepsy? There are several randomized control trials have been done all across the globe. The first one came from Canada and the recent one came from India. And all these trials have clearly shown that the seizure freedom after epilepsy surgery is significantly higher when compared to the medical arm. It's almost 80% when you do epilepsy surgery and only less than 10% in medical arm. So 80% of the people after epilepsy surgery will become seizure free. So even in SUDAP risk also will become significantly lower once you do epilepsy surgery and the patient will become seizure free. So these are the patients who had undergone epilepsy surgery and these are the medical treatment arms. So you can see that the risk of SUDAP is significantly lesser when the patient had undergone epilepsy surgery and they have become seizure free. So once you do epilepsy surgery and when the patient becomes seizure free, the chance of dying because of SUDAP, that is sudden unexpected death, is significantly lesser. So that is another advantage of epilepsy surgery. Then they fear about complications. So, but if you look at this complications rate, the major complications is just around 5%. That's almost equal to any other surgery. So we don't need to fear about epilepsy surgery. Then they fear about cost. It may be more costly. But this study came from France and they have shown that epilepsy surgery is really cost effective. In fact, it is over the period of time, it is, in fact, it is better cost effective than the continuous medical therapy. So what are all the options we have for epilepsy surgery? I think Dr. Bhupesh will throw more light on this. There are three main types. I'll let Dr. Bhupesh talk more about this. So there are several options for epilepsy surgeries. So how should we evaluate a patient with epilepsy or refractory focal epilepsy? Generally, the first step, we'll do a scalp EEG for 3 to 5 days to record the seizures. Then we'll proceed with the MRI brain. For example, you find that the EEG shows there is some abnormality in one particular part of brain, and MRI brain also shows a structural problem in that area, then we'll straight away go ahead with an epilepsy surgery. We'll go and remove that area. Suppose if these things are inconclusive, there are several non-invasive advanced imaging modalities like PET, SPECT, MEG, and electrical source imaging. So after doing all these things, depending upon what we are finding, we can go ahead with the surgery or we can do an invasive EEG monitoring and then we can proceed with epilepsy surgery. So I'll come back to our patient. So we did a 3 days video EEG and we have found that there are lots of generalized discharges in the EEG. And in fact, they are more over the right hemisphere, right frontal, that is and the anterior aspect of our brain. So when they recorded the seizure, even though the seizures are in fact involving both sides of the brain, they were more prominent over the right frontal area, right anterior aspect of the brain. When they did MRI brain, we could find a structural problem. This is the right frontal cingulate area. There is a thickening in the right frontal cingulate cortex. So that has been confirmed in multiple MRI sequences. So we did right frontal, cortical, and cingulate section under lots of advanced neuromonitoring like electrocardiography, motor evoked potential, and in fact, we have used the brain navigation system also. So these are the advanced neuromonitoring techniques. In fact, if you do the surgery in some advanced countries like USA, the same monitoring systems will be applied. So we have so much advanced techniques nowadays, and the operative histology also came as focal cortical dysplasia. That's what we suspected from imaging also. And the child had become completely seizure free after the epilepsy surgery. So from 100 to 200 seizures per day, the patient immediately becomes seizure free after the epilepsy surgery. So that's the impact of epilepsy surgery if you do it correctly. So what are the take-home messages from this talk? So any patient who has a drug-resistant or drug-refractory epilepsy, that should be referred as early as possible. And epilepsy surgery will provide a significant amount of seizure freedom, and the patient will lead on to a better quality of life. The complication rates are very minimal and very acceptable. Even if the patient's MRI is normal and it involves some eloquent areas of the brain, still they can also be a surgical candidate. And finally, and very important, the surgery should not be the last resort. So any patient who is not responding to the medical treatment, that means the first two drugs, if they are not responding, then the patient should be referred to an advanced epilepsy surgical center as early as possible. Should not be the last. The epilepsy surgery should not be the last resort. So I'll conclude with this, and I'll be very happy to take any questions at the end. Thank you very much for this wonderful opportunity again.
Thank you so much, doctor, for explaining it in very simple terms. What is refractive epilepsy and what are the treatment options available and the advantages of going for epilepsy surgery when the medications fail. Thank you so much, doctor. Now, may I invite Dr. Bhupesh to go ahead and make his presentation?
Yes, thank you.
Doctor, just before you begin, let me again ask our viewers who are watching this discussion to post their questions in the Q&A box. We will take it after the presentation by Dr. Bhupesh is over. Thank you.
Is the presentation visible?
Yes, doctor.
Okay. Good afternoon, everyone. I would like to thank the Naruvi management and the Hindu magazine for giving me this opportunity. This talk is on epilepsy surgery. I would like to keep the presentation crisp without medical terminologies. The previous speakers have almost explained everything in the basics of epilepsy. I would like to go into some pictures, something interesting to get what is there in not even US or international styles. India, in our place, in our locality, we have almost everything that Dr. Muthukani has told. We have everything here. So I'll start with the presentation now. Surgery for epilepsy is indicated when there is a lesion on an MRI, which is considered as a source of a seizure. Example, a brain tumor. Otherwise, the surgery is needed when the seizures are not controlled by medications or have side effects due to medications. So I'm going to speak about surgery for abnormal MRI, which is simply removal of the abnormal brain. Next, I would be talking on the surgery for seizures in normal MRI brain patients. And I would be going to talk on the procedures to locate the seizure focus and ablate it. This is a technically challenging and a very less invasive. Then I will show some of the new procedures which have not become mainstream, but yet promising. This slide is important to understand the presentation. This slide shows a normal MRI brain. If you would have noticed fish slices, this is a brain slice. So we take a 3D image of the brain and then slice it in the orange line that you have seen. This is the normal brain. You may not appreciate the normal brain unless you know what is abnormal in the brain. So this is a very difficult situation to identify a normal brain. But if you see in a mirror image, both the mirror image appearing to be the same, it is normal. So going to the next slide. This slide shows a lesion in the brain. The adjacent image shows that the lesion has been removed by surgery. I have marked a circle in the right side of the image for our understanding. So this is how a seizure, as Muthukani is already told that, this is how a lesional epilepsy, lesionectomy, a removal of a part of the brain which is involved by a tumor or a altered structure which has to be removed will reduce the seizure burden. So now you have seen a abnormal MRI, but this is a structural image. Now the next slide shows a normal MRI. But there are, this is a metabolic image, the PET image. This is taken not only because of the structure, it is because of the metabolic function, where you can see that the white circle area did not have enough oxygen, glucose that is being taken in by the tissue, so that you can see that it is not reddish compared to the opposite side. So this is the opposite side, and then the right side, and then you can see that the white circle areas is completely not red. So this is the area where the seizures originate. So the images, MRI images below shows the excision of the lesion and then seizure freedom. So what happens if MRI and PET-CT is normal, but the patient has seizures? Here, the neurosurgeon can help the neurologist to identify the potential parts of the brain from which the seizures arise. We place electrodes in different regions of the brain suspected to have a seizures originated. Electrodes are nothing but wires. This can be done manually or using robot. Previously, it was done manually, so it took nearly 12 hours time. Now with the robot, we can do it in 6 hours time. So the what happens here is that once the electrodes are placed, the neurologist will evaluate the patient in the special ward in called an epilepsy monitoring unit. He will stimulate the brain with the microcurrents through the electrodes and try to bring out the seizure the way it is produced in the patient. Dr. Muthugani told it was a semiology. That is what the epileptologist will try to do in the epilepsy monitoring unit. It would take at least a few days or week. At the end of the assessment, the neurologist will be able to tell us that these are the possible sources of areas of the brain that are the foci of epilepsy that is being originating, and then it has been traveling. So they will give the list of electrodes and the contacts in which has to be ablated, so that the seizure originating foci and the area where it spreads can be ablated. So ablation is done using radio frequency. We can also be done with the laser. Okay, coming to the next slide. This is a video of a short video about a robot which is used for epilepsy surgery. We have the latest model here in the hospital. This is a robot works. This robot works with in concurrence with the MRI image. It shows where in the brain the location. It is also like a navigation device. We also have a navigation device. We also have an intraoperative monitoring. Along with this robot will let us know in 360-degree space at exact point inside the brain where to place the lead and where to keep it as you read on the MRI. So with sub-millimeter accuracy. So this is the laser that I'm talking about, that I already told about. This is something which has not reached India. And instead of robot and inside the theater, this is done in the MRI scanner room, and the robot is in the MRI scanner machine attached to the machine. It works with giving laser and then increasing the temperature locally. And this is thermocoagulation. So this temperature increase is shown on the MRI image, and then they will ablate the lesion. Then the next few slides will show only the very recent advanced treatments, not getting into the brain at all. So this is vagal nerve stimulation. Vagus is a nerve that arises from the brain and goes up to the intestine. It also supplies the heart. A pacemaker like device, this is like a heart pacemaker, and it sends stimulated signal to the brain, and it will control the seizures. This is called vagal nerve stimulation. Then we come to similarly, they have two pacemakers that will be used for the seizures in the brain itself. One is called the deep brain stimulation. The other one is called responsive neurostimulation. Deep brain stimulation is commonly used for Parkinson's disease, and it gives a very good result with Parkinson's disease. For epilepsy, they are still trying it out, and then the results are yet to be promising. In the future, probably without cutting or gross surgeries, we could just use this battery and electrical device to control the seizures. The responsive neurostimulation is something very interesting, because there are two leads here, and the one lead that the lead will identify the seizure foci. This is placed in the seizure foci. Whenever there is a seizure that starts, the spark comes, the other one will send the inhibitory signal so that the seizure gets controlled. This is like with the with computer control, we can do it. And the battery is not even placed anywhere else. It's placed within the bone itself, in the skull bone itself, so that the patient will not be known that he had a seizure or any surgery being done. So this is the last slide, I think. Yes. So thank you for giving me this opportunity. And the take-home message here is that seizures can be treated very imminently, if not with medicines, with surgery. And we have every possible gadget that is available anywhere in the world here itself, in our hometown, Vellore itself. So it's not a big stuff managing a seizure patient. All we need is to have a confidence, because the way that the surgery has been projected earlier, 100 years ago, for example, is cutting a larger chunk of a brain. Right now, we identify only that part, the candidate part, electrical circuit inside the brain, and then target it and ablate it. Thank you very much.
Thank you so much, Doctor. Thank you for explaining the cutting-edge treatment options available at the present. Let us hope that some of the very advanced technology that you mentioned also become available in India very soon, so that it can benefit a lot of patients here. Thank you so much, Doctor. We have a few questions coming up. So probably, since we have around 15 minutes left, I will start with the viewer's question first, and maybe later, if we have time, I will ask some questions as well based on the discussion. First question is from Mr. Debashish Chakrabarti. He has said that my son, 18 years, never had seizures or fits, but was diagnosed to be suffering from epilepsy based on ECG reports. He was very volatile, violent, and unobedient. Last 5 years, he has been prescribed Dicorate ER 1 GM, valporic acid 1 per day, and he has improved a lot. Please advise future course of treatment for him. Dr. Muthukani, would you like to take that question?
Yeah, I'll take. Yeah. So I don't know. Like they are saying that that son never had a seizure. So it's probably based on some EEG findings. I'm not very sure whether he really had an epilepsy or not. So generally, we don't just start treatment just based on EEG alone. But whatever, like the child seems to be having some psychiatric problems like violent and unobedient things. So that might have been improved with the Dicorate, that is a valproate. So it has a mood stabilizing property also. So I don't know whether by having this mood stabilizing property, that child improved, or it manipulate, or it controlled whatever there was in the EEG. So I think we need to see the patient and assess him properly. And if required, we need to do and repeat long EEG, because sometimes the short EEG which we do in our routine practice may not help us. So in that case, we can plan for overnight video EEG to exactly decipher what is the problem, and we can manage accordingly.
Thank you, Doctor. We have another question from Maria Jolda. She has asked, Sir, I am a patient having epilepsy for about 13 years. I am taking medicines continuously, oxcarbazepine, clobazam. She has mentioned the medicines that she's taking. And this is actually an increase in medicines. My doctor wants me to take video scan for 3 to 5 days. My seizure timing will be for once in a month. Mostly I'll get seizure when I'm tired. My MRI and EEG is normal. Do you think that a surgery is required for me? Dr. Bhupati, Dr. Bhupesh, sorry.
Yes.
Would you like to answer that question, Doctor?
Actually, this is actually completely to be evaluated by the neurologist and epileptologist before deciding about surgery, because the EEG and MRI is normal. Should he need any other imaging? Should he need invasive EEG to identify? All this has to be confirmed as a diagnostic stuff. Means we need to know if there is a epileptic foci and where it is.
Right.
Then only a surgeon comes into the picture.
Okay.
So surgery is not required in the first place, and we have to identify whether the drug that he is taking is actually necessary for the seizure type that he is having.
Okay. Right. Thank you, Doctor. Then we have another question from Ms. Preeta MP. Good noon to all. I underwent a craniotomy for SDH in 2018, where I found my left side became dysfunctioning. I've been taking Levipil 500 mg until last follow-up. All my MRI and EEG are normal whenever I took, but I found discomfort on my left leg and hand whenever I get tensed or shout at my students or husband. May I know the cause for the discomfort, as I'm afraid whether I may go to the former state. My doctors just shut my mouth not to confuse my brain. I am advised to stop Levipil from this month. Kindly bear with this long narrative question. Dr. Chitramala, would you like to answer that question, doctor?
Yes, sir. This patient has had a subdural hematoma.
Right.
Subdural hematoma is a blood clot which occurs inside the skull but outside the brain.
Okay.
So these patients even can have a seizure at the time of a subdural hematoma, where it is called acute symptomatic seizures.
Okay.
And these acute symptomatic seizures, once the cause of the seizure is removed, they don't even need drugs. But this patient says she never had a seizure. Her EEGs were normal. So an acute symptomatic seizures, even if there is a seizure, if the cause is removed and the EEG is normal and the brain has no scarring, the corresponding cortical region of the brain has no scarring, we don't give anti-epileptic drugs. But this patient who has had a normal brain, she never had a seizure, she never had an abdominal EEG, and the symptom that she says is also some vague discomfort. I tell you, only to make a diagnosis, first the symptom should be a little clear. She says vague discomfort, that too when she gets tensed. I think, I don't know, this does not look like an epilepsy to me. See, there is what is known as a remote symptomatic seizure, something called a remote symptomatic seizure, where the subdural hematoma would have caused some damage to the cortex and then a nearby cortex, and that later, about even 10 years later, they can have a seizure. But this doesn't look like that also. I don't think, I think she has to be properly examined, and more history has to be taken. And I think she doesn't have an epilepsy.
Okay. Thank you, doctor.
But sorry, actually, this is a case of neurosurgeon, Dr. Bhupesh, but this patient is more concerned about epilepsy. I'm answering. I think this lady does not have, this patient does not have an epilepsy. But Muthukar, you want to add to this?
No, sir. I think I completely agree with what you said. So I think we can stop the medicines, and if required, we can evaluate at a later point in time.
Yes. And again, I tell people, whenever they have a suspected epilepsy, where EEG is normal, everything is normal, I will let the bystanders, the relatives, take now everyone has a cell phone at home in hand. Take a video of this and what really happens. See, this patient says she has discomfort. At the time, is she aware or she loses her awareness, and how she behaves? Is there any motor movements? All these things will be seen. So this patient, I will advise her to tell her friends, relatives to take a video of what happens at the time. And with the video, let them come and meet their neurologist or epileptologist. I think presently she doesn't need anti-epileptic drugs.
Right. Thank you, doctor. We have many questions coming up, but I think they are also very specific. But I understand that all these questions will require maybe an in-person consultation to get a better understanding of their situation and to make any suggestion by the doctors. So I'll take more the questions that are more generic in nature. There is one question from an anonymous attendee. The attendee has asked, what if the MRI and PET CT scans are normal for a refractory drug epilepsy case? What is the next option? Dr. Muthukani, would you like to take that question?
Yeah, I'll take that. So even if the MRI and PET CT are normal, and if the patient has definite refractory epilepsy, first of all, the patient should undergo a long-term video EEG monitoring to know about, because sometimes we think the patient had only seizures, but sometimes they can have some non-epileptic attacks also. They are not real seizures. They may be just related to our mood-related problems, or so those things can also mix up with real seizures. So we need to find out whether it's completely a true drug refractory epilepsy. And while doing video EEG, we'll come to know where the seizures are coming from. Then we can go back and look at our MRI. That should be a high quality. 3 Tesla we have in many of the places now. Right. So if it has been 1.5 Tesla, then we can repeat 3 Tesla MRI. Then we can compare all these things like MRI, 3 Tesla MRI, PET CT, and whatever we get from video EEG. So even then, if you are not able to find out focus or something, then there are several other options also available. Like there is a scan called Magneto Encephalography. It's like an MRI along with EEG. So Meg Scan is available in 2 places in India, one at Nimhans and another one at AIIMS in New Delhi. So these 2 places we can proceed with the Meg Scan. And then there is another advanced scan is also available called electrical source imaging. So these are the 2 things I think the patient can undergo to find out a source or network. And depending upon what we are finding from these modalities, we can plan for either a direct surgery or an invasive EEG, which Dr. Bhupesh said. So we can plan that also.
Right. Thank you, doctor. There is another question from Pavi Raj. The viewer has asked, my daughter has not experienced any epilepsy before 18 years, but nowadays she is saying that she is biting her tongue often and sudden awakening without any reason, especially at night. Has severe headache after waking up. Are these the symptoms of nocturnal seizure? Dr. Chittambalam, would you like to answer that question? In fact, doctor, I would like to add to that question, which I also wanted to ask. Can you explain to us what is the common age group when a person is diagnosed with epilepsy, doctor? Does it happen at a really early age, or can it happen at a later stage of life as well? Thank you, doctor.
No, epilepsy more common in the younger age group, but it can start at any age. Even the so-called idiopathic epilepsies, they can have onset at a later age, but it is more common in a younger age group. This this patient, what is the specific question they want to ask?
The viewer's correct. The viewer's daughter is above 18 years. Yes. Nowadays, she is biting her tongue often during at night, and she also suddenly awakes with severe headache.
Yes, this patient, I will suggest 2 things. One, a nocturnal tongue biting, where the lateral side of the tongue or the inner cheek is injured. So the patient wakes up in the morning, finds that the lateral tongue is injured, or there is a soreness, or the inner cheek is bitten and there's a soreness. This may be a feature of nocturnal GTCS, nocturnal seizure, where during the tonic phase, the muscles of the jaw go into spasm and they bite the tongue or the cheek. So definitely one. Second is, this patient also has muscle soreness, meaning that this patient has had a generalized muscle involvement, generalized clonic involvement, which has caused a pain. And so these 2 things probably indicate that this patient has had a nocturnal seizures, most likely a motor seizure. Now, what to do for this girl? One thing is, I will even advise them to fix a CCTV in the room and record. And the day when she tells that the morning she finds her tongue being bitten, the previous night CCTV can be analyzed and can be looked back, and you can see whether really she has gone into any motor movements. Second thing is, you can ask a stronger history. See, these people who have a nocturnal seizures, in the daytime they have some unrecognized focal seizures. They are not necessarily motor. They can have a visual seizures, they can have a somatosensory seizures, they can have an auditory seizures, they can have an automatic, they can have an autonomic feature, they can have emotional features, cognitive features. So very strong, very deeply you have to ask questions whether in the daytime she goes for blank smells or vacant stares. So that is very important. Third important thing is, she has to undergo 2 investigations. One is an EEG. The EEG, very, very particularly, this girl has to go with the sleep deprived state. For example, she sleeps from 12 o'clock in the night to 3 o'clock or 2 o'clock, and after that she never sleeps, and she has a good breakfast like a pongal and goes and sleeps while the EEG is being taken. A good sleep record will show whether there are any discharges. Most probably this can be a focal or generalized, but most probably a focal is possible, and a good EEG. And if so combined with the CCTV evidences, the history, very strong, very deep history, and good quality sleep deprived EEG, which has a sleep recorded during the EEG recording, and a good quality 3-test MRI. With all this, I think you can come to a conclusion whether this girl needs to be treated or not. But has to be considered. You cannot neglect it.
Right. Thank you. Doctor, there are a couple of questions that are related to continuing the drugs. So I'm going to combine that as a general question. There is one from Augustine Lawrence Walter and another anonymous attendee and one more as well. So they have asked, I think their relatives are undergoing medication for epilepsy and they seem to be reacting to the medicine. But their question seems to be, for how long should the medicines be continued? Or can they be stopped at some point in life?
So again, stopping the epilepsy drugs. I'll just then we'll also ask Dr. Muthukani. But stopping the drug is not a general rule. Epilepsy is not a single disorder. The epilepsy has many. That's why I told, in treating epilepsy, you will have to make a diagnosis of what is the type of epilepsy, what is the cause of epilepsy, what is there any epileptic syndrome, what will be the prognosis, what will be the cause. So the treating physician has to be very clear about that. There is no general rule that if for 2 years you don't have epilepsy, you stop it. No. So these patients have to consult their epileptologist, and they should try to make a definite diagnosis of the epilepsy syndrome, where you know everything about epilepsy. Where is the lesion? What is the lesion? All that. So depending on that, you can try stopping the drug. Otherwise, if there is no seizure for 2 years, if you stop it, then it will lead to recurrences, and recurrences are again not good. So stopping the drug depends upon the particular type of epilepsy, cause of epilepsy. Dr. Muthukani, you want to add to that?
No, sir. I think I'll agree with that, sir. So it depends upon like what they had, what type of epilepsy they had, and what is their MRI and EEG findings are. So depending upon, though the general saying is like generally, if there is like, if the MRI is normal, EEG is like some mild changes, generally we give it for 2 years, then we'll discuss with the patient discuss with the patient about the option of stopping the medicine and about the chance of recurrence and all. Then we need to take a call.
Right. Thank you, doctor.
So a patient who has tried stopping the drug for 2 times, 3 times, again is a record. I think this patient, even in the syndromic diagnosis, not very clear. Stopping again is risky.
Okay. Right. Thank you, doctor. And doctor, there is one question from Varna K. The viewer has asked, why don't neurologists ask for sodium test reports to check if it is an epilepsy or seizure, but ask us to bring MRI and EEG reports and start epilepsy medication? I had seizures/epilepsy 7 years ago twice and stopped medication after reducing dosage. Now, last week I had seizures and doctor has put me on 100 mg dosage again. My MRI and EEG reports are always normal every time I had seizures. I would have had less sleep or tiredness the day before.
Yes.
Dr. Muthukani, would you like to take that question?
Yeah. So like, so this patient's EEG and MRI are normal, but apparently, but the patient had repeated seizures. So that's why the patient was put on medicines. But again, like in many patients, almost like more than 50 to 60% of people with epilepsy, MRI will be normal. So it doesn't mean that the patient is not having epilepsy. So that's one thing. And EEG, again, it depends upon like how we do, when we do EEG and how long we do EEG. For example, if you do a routine EEG means you do record EEG for 20 to 30 minutes in a day, then the chance of picking up some abnormality is only less than 50%. It's around only 30 to 50%. And if you record overnight EEG, then the chance of picking up some abnormality is around 80%. So I would suggest this patient, suppose if they have doubt that, or do they really have epilepsy, but it's clinically definitely epilepsy. And again, EEG is an ancillary or additional, it can help the clinician to just to add up that. Okay. So, but epilepsy is more of a clinical diagnosis. So if the patient had repeated seizures, then it is necessary that the patient need to be taking the medicines regularly, maybe for a longer period of time.
Thank you, doctor.
This patient, even after so many years of epilepsy, she's telling normal MRI, normal EEG, and seizures, but she's not very definite about what is the real epilepsy type she has. So I think patients after at least years of seizures, they should be clear about, they should even ask for a diagnosis. So, for example, patients who are communicating, who are asking the question, they only describe their features. They describe that they have normal scan, normal EEG, but none of them are coming out with diagnosis. For example, one girl who has asked about an oxcarbazepine clobazam, she should tell what is the diagnosis. I am suffering from mesial temporal sclerosis related medial temporal epilepsy. I am suffering from a focal cortical dysplasia. I am just suffering from a genetic generalized epilepsy, like that. After investigations, at least a probable diagnosis has to be made, and only if the diagnosis is clear, then we know when to stop, whether to restart, how much to restart. See, for example, some of the idiopathic generalized epilepsy syndromes, like a juvenile myoclonic epilepsy, they need the least possible dose. Like the patient says, what is the drug that she didn't mention? It is 1000 milligrams. For example, even the minimum possible 500 milligram per day may be enough. So in some of the seizures, you need to give a higher dose, and some of the seizures, the lowest possible dose is enough. So again, that's what we are trying to stress is every patient who has epilepsy, who has been given the diagnosis of epilepsy, should try to know that what is the exact diagnosis. A little more expansion on the epilepsy syndrome, epilepsy type, epilepsy cause, and the diagnosis is not complete if they just say that they have epilepsy. Probably if you know the entire thing, probably we know when to start drug, how long to start, what to start on all those things, right?
I understand.
I found that was an autistic child with abnormal EEG. One person I found, a child had an autism, so-called ASD, autism spectrum disorder, and the child never had a seizure. The EEG showed epileptic form discharges. Now again, the child is 15 years. If the mother wants to ask whether they have to start tamoxifen or an anti-epileptic drug, not necessary. I don't think there is a need for anti-epileptic drug in this child with autism spectrum disorder, who has never had a seizure but has had only abnormal EEG. So that particular person I noticed. So I want to tell the mother that child does not need anti-epileptic or anti-seizure medications.
I understand, doctor. Thank you, doctor. It is very difficult to answer the question with the minimal amount of information that we have. Thank you for explaining that. And
the minimum information they give, we want to stress that they should be informed. The people with epilepsy should try to know more about the epilepsy, and by the way they talk itself should tell us that they are very clear about what syndrome they are suffering from.
Right. Thank you. Thank you, doctor. So we have run out of time, but more questions are coming in. So probably we'll take another 5 minutes maximum to answer 2 or 3 questions quickly. There is one question from an anonymous attendee. After surgical epileptic treatment, should a child continue anti-epileptic drugs? And I would like to combine that with another question from another anonymous attendee asking whether epilepsy will affect the studies of a child. Dr. Bhupesh, would you like to answer these questions?
Yes, sure.
Yeah.
This I've seen this.
Yeah.
This actually the surgery will help reduce the seizure frequency, and we have classifications how much seizures are reduced. It can be at least almost no seizures after surgery, or some seizures after surgery. What we try to reduce is that the dosage, the toxicity related to the drug dosage. Number 3, the number of seizures that they are going to, like for example, if they have a drop attack, the number of accidents that they are going to face in the future, or at the most, no seizures. So a goal will be 100% seizure freedom, but what we reach is probably 95% or 90%, depending on how it has been analyzed, how long they had, what are all the changes that is not been accessible. Say for example, the area of a brain which cannot be knocked off by doing this procedures or anything, which would land up having in a comatose stage for a longer duration. We can't do that. So we have to modulate between what is their presenting condition and what is the realistic life that we are expecting them to be, and then the procedure. It is not always 100% always.
Okay. I understand. Yeah.
So that's one more thing on the next part of the question is that
will it affect their studies?
Yeah, because either the seizures will affect the circuitry inside the brain, they will have poor scholastic performance, or the drug effect will affect their concentration capacity. The seizure itself will change the mood. The seizure itself will cause psychological changes which they would not be able to handle in the regular school work performance. Even academic, not only academic, even work performance can also be affected. This is again rehabilitation. Whenever there is a surgery, there is a need for rehabilitation. We didn't address the rehabilitation part here because that plays a major role other than surgery itself. Rehabilitation part is more important, and this is where we bring a patient and mix it with the population. So there is a vocational rehabilitation, there is a occupational therapy, there is a physiotherapy, speech therapy. whatever that they are trying to modulate their activities so that they could work or live like a normal individual.
Right, right.
But there will be some change, there will be some difference between a normal individual and them.
Right, right. Thank you, Doctor. Dr. Chitrambalam, I would like to answer you a question. Ask you a question. You mentioned during your presentation about the GTCS seizures, right? I mean, some patient may come to hospital saying that, this is the first time they've had seizures. But when you actually examine them, they may have had non-motor seizures for many times before. So that is sort of going undiagnosed and unnoticed. So in such cases, what do the patients can do? What are the symptoms that they can look for even to detect such non-motor seizures and immediately get medical help, doctor?
Even motor also sometimes miss. For example, patients with idiopathic generalized epilepsy, they have a myoclonic jerks. The only symptom will be they drop objects. In the morning, they would have dropped a tumbler of coffee. They would have dropped a comb when they are combing. So these dropping objects is an important thing which tells you that the patient has had myoclonic jerks. And the second, the most important small seizure that I missed is a blank spells. While talking itself, suddenly the patient keeps looking at the ceiling, then he comes back to the discussion. So these blank spells, they were called so-called complex partial seizures. Now the term will be focal onset non-motor seizures with loss of awareness. So these are the and again, sometimes even vivid colors they will see. Suddenly patients will see beautiful green, red, yellow in front of the eyes, then they will disappear. These are the visual seizures. These are some of the, and again, as one patient asked, many times this nocturnal tongue injury is missed. So all these things are very important observation that we'll have to get from the patient's relatives and the patients to say whether this is not the first seizure, and many times the patient has had a seizure but not convulsive.
Right. Thank you, Doctor. Dr. Muthukani, I would like to ask two questions together to you, and with that we will bring this discussion to an end. One is about the side effects of drugs. Many people have asked about, they are taking a certain medicine and because of which they are feeling sleepy and tired all the time. One person in particular has asked, he's taking Briv medicine, feeling sleepy and feeling like inactive. What can be done? Can you explain what are the latest, efficient drugs that are available that can mitigate these side effects? That's number one. And during your presentation, you also mentioned about the side effects, certain consequences of facing epilepsy. One woman, how she burnt her fingers because she was standing right in front of the stove. So can patients suffering from epilepsy anticipate these events? Can they be aware of certain trigger points which will help them, stay away from such hazardous environment, at least to go through that epilepsy in a safer environment? That's my question to you, doctor. Thank you.
Okay, so to answer the first question, none of the medicines are side effect free. Okay, so all the medicines will have some side effects. It varies from patient to patient, and it also depends upon the dose they are taking. So generally, this mild sleepiness feeling and tiredness feeling after starting a new medicine, generally it will go away once the body adapts to the new medicine. Suppose if they are still not tolerating that medicine, then it would be better to either reduce the dose if possible, or we can change the medicine if they are not tolerating that. So these are the options we have. And regarding the second question, not all the seizures we can avoid. Suppose, especially if they have an aura means they will get some feeling before the actual seizure starts. For example, if before a major seizure, major convulsive seizure, some patients may feel like something comes up from their stomach, or they may feel like vomiting, or they may see some colors, or they may feel some abnormal sensation in their hands which is going up. Suppose if they have any signal that the actual seizure, the major seizure is going to come, then they can either inform the relatives or bystanders and they can move to a safer place. But not all the patients will have that aura. So if they don't have aura, then it would be very, very difficult to prevent the seizures or prevent the seizures from occurring, or prevent the accidents and injuries from happening.
Thank you.
Thank you so much. One thing I would like to add.
Yeah,
so this regarding that the medicine, or whether we can stop the drugs after epilepsy surgery. If the patient has become completely seizure free after epilepsy surgery, generally we start reducing the medicines at the end of 3 months. And there is an option that we can completely stop the medicine in around 50% of the patients. So if they have become completely seizure free after epilepsy surgery, then definitely there is an option that we can stop the medicines completely, but it all depends upon how many medicines they were on and what was the finding we get from the histopathology after the epilepsy surgery, and whether they are really completely seizure free, and what is the post-operative EEG finding. So it all depending upon all those things.
Thank you so much, doctors. I think the entire session was very informative to a lot of viewers. That can be seen from the number of questions that we got today. I hope it was helpful for a lot of audience. And the recording of this session will be available on YouTube as well for anybody to watch it later. Thank you so much, Dr. Chittambalam, Dr. Muthukani, and Dr. Bhupesh for joining us today and enlightening us on epilepsy. Thanks a lot. Thank you.
Thank you.
Thank you.